Hi, this is Brian Kim. I'm going to share with you case number 91 in the best way to do cataract surgery series. This is a standard dense cataract in my practice, and you're going to see double chop, cross chop, reduced use of ultrasonic energy, and systematic lens disassembly. You have heard me say many times that with dense lenses, you can utilize a lot of ultrasonic energy, and that can lead to corneal edema. You could have a higher risk for grabbing the posterior capsule with these maneuvers. By using mechanical forces, you're able to reduce the use of ultrasonic energy and keep away from the posterior capsule while you're disassembling the lens. So I'm using a cotton tip to steady the eye. I'm using a corneal marker, which will help me to center and size my rhexis. This is my paracentesis incision, first on the right side and then the left side, and make sure I'm parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. I'm using some intracameral lidocaine and then some intracameral epinephrine. And this is dispersive viscoelastic to fill the anterior chamber and coat the corneal endothelium. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and when I'm ready, I use a cannula to turn the eye towards me, and then I enter. Inject some more viscoelastic at the end here. Go in with the teeth sideways for my puncture style rhexis. Go ahead and puncture. Pull towards me. I'm able to get a nice tear there, grabbing the right side of the tear, making sure I'm controlling it so that it's the appropriate radius so I can start the rhexis. I go around, grabbing and re-grabbing, pulling the flap, trying to stay within the corneal mark, which will hopefully help me center and size the rhexis. Finish the rhexis, burp some viscoelastic out. This is the capsular fornix hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, get to the fornix, point the tip down, get a nice wave, rotate the tip back up, decompress on the left side, point the tip down on the right, and it hooks the lens and it spins quite easily there. Irrigate the surface of the eye. I'm turning the sleeve so I get a little bit more exposure with these dense lenses. I lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. Remove the surface epinuclear material, which is minimal here. Place the chopper under the rhexis edge contra-incisionally. Place the phaco tip vertically sub-incisionally, bringing both instruments together, slowly crushing the lens completely in half, separating it, making sure it separates, placing the chopper around the right heminucleus, pulling it centrally towards the phaco tip, dividing the right heminucleus and making sure they're all separated. That is double chop and cross chop. Placing the chopper around that first quadrant, crushing it with the phaco tip, and then using successive crushing forces to break the lens into smaller pieces and emulsify those smaller pieces. Manipulating the lens piece with the chopper and then grabbing it with some vacuum and then emulsifying it. So we're going after the second quadrant, placing the chopper around the lens, placing the phaco tip deeper, carefully, slowly, dividing it, separating it, grabbing it with a little bit of vacuum, pulling it up, crushing it again, dividing it, crushing it again. I keep crushing the pieces until they're small enough, and then I emulsify the lens pieces. Loosen up that last remaining piece of that second quadrant, lifting it up with the phaco tip, and then crushing it with the two instruments, and then emulsifying the lens pieces. I'm just removing the rest of that stuff. It's really thickened and stiff epinuclear material as well. Just going to rotate that second heminucleus in front of me, placing the chopper underneath that lens piece. Careful to make sure I'm under the rexus edge, making sure I've hooked it well, pulling it centrally towards the phaco tip, and then dividing that lens. Placing the chopper under the third quadrant, making sure I'm under the rexus, hooking it, and you can feel when you hook it because the lens stops, and then you can push it against the phaco tip and you can feel it start to fracture. A lot of this is really quite tactile. When you're pulling it centrally and you're having the phaco tip on the other side, as the instruments are closing in, you can feel it. You can feel it encounter some resistance. And then as you squeeze both instruments together, it crushes it. It'll be no different from if you're having chopsticks and you're squeezing them together and you're tapping them together. But if you had a piece of food between the two and you bring the instruments together, you can feel that there's food there, and you have to squeeze it hard together to hold that piece of food. So that's kind of the analogy I would use. I'm injecting some more dispersive viscoelastic to protect the bag. After that, I go back in with the chopper, crush that fragment to a smaller size, and then emulsify it. Rotating the fourth quadrant in front of me, placing the chopper under the lens, around the lens, placing that phaco tip deep. You see, when I do that, I can feel that I don't have it. And that's why I stop. Yeah, you see that when I bring the instruments together and it just slides, and you saw that I stopped and I had to start again, that means that I didn't feel that resistance that I'm referring to. So I just use a chopper to manipulate that last piece up out of the bag, using some vacuum to hold it and then crushing it in smaller pieces and then emulsifying the lens piece. Anytime I'm dealing with the last pieces, I'm just mindful that the bag is okay. In this case, I have a pretty thick amount of a stiff epinucleus. I feel pretty safe. So I remove that last piece and then I go after the epinucleus, which comes out quite easily. Again, it's real thick and stiff, so I have to just very carefully and slowly remove it with the high vacuum. Take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. I always start sub-incisionally, removing the cortical material, sweeping side to side, trying to peel it. By peeling it this way, you're able to get a cleaner removal of the cortical material and less likely to have any remaining fragments there. I go to the left side and then now the right side, peeling it from front to back. Switch to polish mode, polishing under the rexus edge, removing any lens epithelial cells, but also in the process, sometimes you can snag some hidden cortical material. Again, I like the polish mode because it's very safe whenever you're going deep into the capsular bag there. Polishing on the posterior capsule as well, just to make sure there's no remnants there. I think there's some stubborn pieces of lens material on the bag in that corner, so I'm just trying to make sure I get it all. Sometimes with these dense lenses, you have fibrous material that's adherent to the bag. It's hard to get that out. You just leave it. So I'm using the cannula to pulse the subincisional space. Looks pretty clean. And then this is some cohesive viscoelastic to fill the bag. And I quickly transition to the sweeper, polishing under the rexus edge. First on the left side. And then on the right side. With these dense lenses, I prefer to put a 3-piece lens because I do think there might be some zonulopathy in these situations, and if there's late dislocation, I can lasso some suture around a 3-piece haptics. So I go ahead and widen the incision. I go in with the 3-piece lens with the bevel pointed to the left. I deliver the leading haptic into the bag pointed to the left. Rotate my wrist counterclockwise so the optic comes out flat. Make sure the trailing haptic comes out pointing to the right, outside the eye. Dial in the trailing haptic with the Maltzman. So I go in with irrigation off, activate irrigation, go under the lens, removing the viscoelastic from within the bag, remove the viscoelastic from within the anterior chamber, and then I'll hydrate my incisions. So again, this is a pretty dense lens. I was able to use systematic lens disassembly using mechanical fracturing, double chop, cross chop. People always debate whether or not you can use a lot of ultrasonic energy. Some believe, oh, you can use as much energy as you want as long as you have the cornea coated. But the problem is the cornea is coated with an invisible viscoelastic, and you can't be 100% sure that the cornea is totally protected if you're going really with high amounts of ultrasonic energy. And so, in my opinion, the best way is to develop a habit of utilizing reduced amounts of ultrasonic energy. By doing it that way, you are assured that at least you're keeping that component out of the equation. And to be honest, if I was having cataract surgery, I would like to have the least amount of ultrasonic energy if it was done on my eye or on my family member's eye. And you've heard surgeons talk about that. That is really the ultimate litmus test. How would you like to have the cataract surgery done if it was your mother or yourself? And this is why I like to use reduced amounts of ultrasonic energy by leveraging mechanical fracturing forces and double chop and cross chop to disassemble the very dense lens. So I hope this was helpful to you, and I thank you for your attention.